Hey guys, so I will be presenting my case study on an aortogram I did with a runoff. The patient information, so the labs were pretty good. They had a few high labs, but nothing that would concern us for our exam. Their allergies were to penicillin. Their prior imaging was an ultrasound that they had done and a CTA of the aorta. The physical exam, they had no visual impairments. They looked pretty healthy from the signs of it. Their anatomy, we were looking at, there was a possible stenosis in the left leg, which we were going to see if we could access and see if we could do anything with, which was shown on the CTA. And then our proposed access site was the right femoral artery. So pre-procedural, same as last one, the medications were checked and gone over by the nurses prior to the exam. They were NPO after midnight, went to AMC before the procedure, so morning of the procedure. Consent was performed by the doctors and nurses. So our patient was able to move. He stood up off the bed, which we brought downstairs. He walked over to the table. We assisted him with a step and 3 of us to help get him on the table and make sure he didn't fall backwards off the table or any weird kind of situations. To keep our dose as low as possible, we have the foot pedal, the collimators, and the timers that let us know when we're hitting an X amount of fluoro. This patient wasn't in any type of precautions, but we were still wearing gloves to make sure we were staying clean. The crash cart was in the same room that we were again, and it had been checked that morning. So our sterile setup tray, our covers were for our II, our monitors, and then our table angio cover. We had a sterile ultrasound cover, which we set up later. We were, like I said, going to access the right femoral artery. We had used ChloraPrep for a bilateral prep just in case he wanted to go over to the other side and access the other leg. We used a 5 French sheath, a torque device. We used a 21 gauge micropuncture needle. This doctor likes a 30 gauge 1.5 needle to numb up. We used an angle glide and a Benson wire. We used a MIC catheter, which that says pigtail. We used a MIC and a pigtail, and then we, of course, used a flow switch. So for this proceeding, we weren't sure what we were going to be able to do due to the CT. We first stuck the patient as normal, numbed the patient up using ultrasound, used the micropuncture wire using ultrasound, put the first wire in, took the needle off, put the dilator sheath on, took that stylet and the wire out, put the Benson down, got our bigger 5 French sheath over that. After that, we took the pigtail catheter and ran it up to the aorta. At that point, we shot the first series of our aortagram, which was the renal arteries. With viewing the renal arteries, we saw that on the left side, there was a blockage coming off the anterior that came off the main and was blocking the anterior one. I had asked the doctor about that because I wasn't sure if that was something we could do. He said that more than likely, no, they wouldn't do anything with it. It would just kind of have to be because there was a possibility of losing the other one. So that was where I saw my renal arteries, which those pictures were absolutely amazing to see the kidneys fill and the kidneys kind of reflux down and drain out. Then we moved on to our runoff. So we took and shot all the way down the legs, and that's where we saw the, we used a MIC catheter and got down the leg. We found where the stenosis was doing a runoff, which was in the left leg. We tried to get a catheter or a wire past it. We were unsuccessful. So at that point, since we couldn't get the wire past that, the doctor decided to call it just because if we can't get the wire through, we really can't get any type of device to help, either a balloon or a stent. So at that point, we did call the case. But So during the procedure, the patient was hooked up to a heart monitor, pulse ox, and blood pressure cuff. The patient was positioned supine. Like I said, we used a pigtail and a MIC catheter. We used the runoff and the power injector. So I don't know how well you guys can see this just because I'm recording it. But so you have back this up a little bit. So right on this side, this is kind of what it looked like that. So it came off, and then right here, almost by the bifurcation, there was a huge stenosis right here. So it was a huge black spot, and then it slowly started to fill around it. He didn't believe that was any problem. He said that we wouldn't do any intervention to it anyway, just because there's a possibility of losing the whole kidney if you try to go that close to the bifurcation. That way you could block off this one too and cause blood flow to stop to the entire kidney. Okay, let me zoom out. So we did see, we saw the aorta, the aortic arch, no, not the aortic arch, that was a different case. So the aorta, we saw the renal arteries, and then all the arteries that spread off those. We went down and pretty much saw all of the legs, all of the arteries in the leg, in that left leg, just because that's where we were mainly focusing. But we did shoot up high into the kind of higher abdomen too. So our patients are always recovered up in ambulatory care. So he was told that he had to lay flat, bed rest for 6 hours, no moving your head, just because that open site can pop back open. He was monitored because we did give him conscious sedation. And yeah, that was my aortogram, which I got to see my renal arteries. Thanks, guys.